Welcome, Sara. Great to have you back.
Well, it's always good to be with you.
Thanks for your time. I know you're incredibly busy, so it's wonderful to have you. And I have so much gratitude and respect for you as such a huge leader in women's health. And maybe we could start with people who are maybe less familiar with your work around what drove you to take this huge stand for women and the representation of women in healthcare?
It's such a good question. It takes me back to medical school, where I really felt like what I heard time and again, and this is back in 1989, that there was this massive women's health gap. And it felt like, well, if most of the physicians at that time were men, chances are this gap was not going to be filled. Chances are the research is not going to be done. There's going to be a gap in knowledge and treatment, understanding how prescriptions affect women. And so it felt like a really important opportunity to step in and advance the field of women's health. So that's what really got me to do it. I mean, I had a number of influential experiences. Frankly, I loved everything when I went to medical school and rotated through all the different disciplines. But being at a birth and experiencing the transcendence of that moment, seeing that there's this intersection of mind, body, and spirit that comes together in the female body, and being able to witness that and also see all the biases and challenges that come into that moment, that's what got me to say yes.
Beautiful. Thank you. I'm glad. I'm surprised I never asked you that question before, but it's great to hear the magic of birth. Yeah, it takes me back to my daughter's birth and the kind of miracle, right? In that case, for me, it was like the first time I'd seen a birth that wasn't traumatic, because I'd been in the hospital for so many births, way less than you. But as a medical student, it's such an crazy environment to have a baby in. I mean, and thank God we have that for certain kinds of births. But whoa, the medicalization of birth.
It's a huge topic on its own. And I was really fortunate to rotate through the Brigham and Women's Hospital, and they were at the forefront of having, I would say, a broader, more generous labor map that they managed. So they had midwives, they had a midwifery model that was integrated with the physician model. And so many of the births that I experienced were part of this midwifery model. And if you look at, sort of the labor curve and how many centimeters you're supposed to dilate per hour, it's very strict. I think it's called the Friedman's curve. Whereas midwives allow for a little more dynamic range. And that really appealed to me. It felt like this is a model that could be applied a lot more broadly than just birth. I mean, yes, we need it in birth, but we need it in perimenopause. We need it in fertility. We need it in menopause and taking care of women as they get older. So yes, it's a really good point, because we've shifted, I would say, from medicine 1.0, which was very doctor-centered, like, let me do a C-section because I've got my golf game, to medicine 2.0, which was disease-centered. You've got preeclampsia, you need magnesium, end of discussion. To medicine 3.0, which is collaborative. It's got streams of data that are owned by the patient. There's a desire to optimize among some of us. And so we're really shifting the way that we take care of patients. And I think women's health can only benefit from that.
Beautiful. Well, that's a good jumping off point, I think, for this conversation about, speaking of the how narrow the allopathic can be, or medicine 1.0, let's say. When I was in med school, it was sort of like women's health was hormones. It was like there was birth and, there was the, services around gynecology and obstetrics. But as far as women's health, we really just talked about, okay, well, there's hormones to manage, birth control pills, right? And then there wasn't this really nuanced and expanded and personalized, very specific, omic, as you would have said before in the past, way of looking at what are the challenges across the lifespan and how do we intervene in a very nuanced and personalized way, which I think is part of what you're talking about around the soft touch, right, of midwifery compared to, the edge of the scalpel.
That's true. And it's, I love riffing on these topics with you, Will, because you're so thoughtful um, and you're such a leader in a new way of approaching mental health. And I feel like with women's health, you're right. There was a way that it was overly reductionistic. And the focus was basically a simple question. Do you want to get pregnant? Yes or no? And if you want to get pregnant and you're not getting pregnant, we'll check every hormone level. We'll see what's going on. We think, 70% of the time, the problem is hormonal. And so that left women who were not trying to get pregnant, women who were 40 plus and were navigating, I would say, the rockiest time in the female life cycle, which is perimenopause. It left them really without information, research, knowledge, treatment. And that gap that I saw back in 1989 persists today. And it's amazing to me because I talk a lot about medicine 3.0 and menopause 3.0. It's amazing to me that somewhere around 73 to 75% of women who go through perimenopause and menopause don't get the care that they need.
Wow, that's shocking.
So a huge treatment gap. And while hormones start the conversation, it's really the tip of the iceberg. There's so much that goes into what happens with your hormones. If we just stay with the topic of hormones, there's the production of hormones, which is where we tend to focus. There's the transportation, what's going on with your sex hormone binding globulin, what's going on with cortisol, and how is that affecting the levels of your thyroid and estradiol and progesterone and DHEA. There's the sensitivity at the receptor level. There's now 6 different estrogen receptors that we want to be paying attention to, not just ER alpha and ER beta that we've known about for decades. And then there's detoxification. So there's a complexity to hormones that I think most people don't realize. And then more broadly, a woman is much more than just the sum of her hormones. There's this gene environment interface that we want to be paying attention to. And I really thought that we would be further along in terms of understanding genomics and how that creates a blueprint and how you can work around some of the issues that you have. We all have about 5 to 7 issues that we have to work on. How the gut interacts with your hormones. I think of the control system for your hormones as not just the hypothalamic pituitary adrenal axis. It's the hypothalamic pituitary adrenal thyroid gonadal gut axis. So the control system is pretty complex. And, one of the things I've been somewhat obsessed about, and this is a big part of our upcoming certification, is mitochondria. And the way that you inherit mitochondria from your mother, there's epigenetic changes. I think of my own mother and how she handled stress, the foods that she ate. She was born, she's now turning 80. And she gave birth to me at the time of Twiggy. She weighed about 120 pounds. She was 5'7". She smoked during pregnancy. She didn't breastfeed. And I just think about what kind of mitochondria did we inherit?
Right.
And what kind of signaling is going on? I suspect that the mitochondria I inherited were impaired because there's so many things that can change that mitochondrial signal. So yes, hormones are important. And hormones were sort of the thing that the National Institutes of Health blamed as a reason for the research gap. Women are too complicated, their hormones change too much, such that women weren't required to be part of research studies until 1993. And sex wasn't used as a biological variable until 2016. And that was just 9 years ago. So yes, women have so much complexity, and yet we also know a lot about how to help them live a fuller, better life. We know a lot about the top 10 killers. Now they affect women versus men. And yet women still have a higher mortality rate when it comes to cardiovascular disease. They show problems at lower glucoses in the prediabetes range, like 115 to 120 before diabetes. Most of the criteria, like for diabetes, were defined in men and assumed to apply to women, and that may not be the case because we show vascular damage at lower glucoses. So yes, there's a lot of complexity beyond just hormones.
Wow. Well, tell us about why are you excited about teaching about women's health with IPI right now? Why are we doing this together?
Well, I've devoted my career to women's health, so I feel like this next exploration with IPI, with you and with Keith and all the folks who sign up to work with us, is it's a critical next step in closing that gender health gap. So my hope is that people really learn the underpinnings. They understand how to take the scientific evidence and translate that into meaningful, practical information. So, if I had to just come up with a couple of dreams for how women could be cared for differently for the folks who complete this certificate, I would say, number one, being able to manage cortisol, being able to understand the stress response, being able to have clarity about how women are different than men when it comes to the stress response. And that maps to mental health issues. We know when men and women are exposed to the same trauma, such as wartime trauma, that women have higher rates of post-traumatic stress disorder. We know that women have double rates of depression. We know that they've got double the rates of insomnia, double the rates of Alzheimer's disease. And whenever I see that 2x, it always makes me think, okay, there's something we're not paying attention to here that we need to be paying attention to.
Right.
So cortisol, I think, is such a critical issue. There's 24 different areas of the brain that are sexually dimorphic, that are different in women versus men. The female brain dramatically changes after 40. I want folks to really understand that and to realize that there's so many lifestyle things that you can do, as well as hormone therapy. So all of those women going through perimenopause and menopause who aren't getting the treatment that they need, I want them to get the treatment they need. At least have a discussion about it and whether they're a good candidate. And I would also say that it's not as simple as, should this woman have hormone therapy, yes or no? Women need to go beyond hormone therapy.
Right.
They need to be managing their muscle mass because that is the organ of longevity. They need to be managing their cardiometabolic function. So my hope is that the certificate really helps bring a cohort of people into this new age of medicine 3.0.
Your enthusiasm is so infectious. I love it. And I so appreciate the way you you show up and take a stand for this, 52% of our population, right? I mean, more than half. And, as you were speaking about heart disease, which is one of the things that's so under-recognized in women, I started thinking about this patient of mine who I treated for many years, dear, beloved psychotherapy patient. I mean, absolute amazing person, terrible trauma, who died of a heart attack out of the blue. I think she was something like 52. And this was so many years ago. I mean, 15, 20 years ago. And I was thinking to myself when that happened, how did that happen? This is supposed to happen to men. This doesn't happen to women. It does happen to women. It absolutely does happen to women. And so it's sort of like this bigger picture conversation is so critical. And I think, for us, it's like the time is now to start pushing to help people like you turn the ship around and to really get these advanced tools out into the bigger impact, bigger circulation amongst practitioners. And, as always, for me, it's the education as a mental health practitioner is about not that I'm going to become a cardiovascular disease in women expert or practitioner. I'm probably not going to prescribe statins or aspirin or, do treadmill tests on women or sestimibes or whatever they're called, those things, crazy things. But I need to know ahead of time what these risks are and know how to assess them or make accurate referrals for people so that a wider range of their challenges are addressed in a really proactive way. And I feel like, I really, if I had known then more of what I know now, that person might still be alive,
Mm-hmm.
Anyway, these are.
I'd like to speak to your patient because it makes me misty to hear about this experience that you had with her. And I think it might be helpful just to go through some of the myths that exist when it comes to women getting older and their risk of cardiovascular disease, because I was taught that you don't have to worry about it until after menopause. That's when women start to catch up to men. And that is not true. Mm-hmm. So the population that has the greatest increase in admissions for acute coronary syndrome is women aged 35 to 54. Hmm. So pretty dramatic increase over the past, I would say, 5 to 7 years. And that's mostly because our cardiometabolic health has declined so much in the United States. So you think about the people with polycystic ovary syndrome or the people with prediabetes who are starting to damage their blood vessels in their 20s and 30s. And right. So for the patient that you described, the other challenge is that so many people aren't aware of the way that acute coronary syndrome or a myocardial infarction shows up in a woman compared to a man. Women have smaller coronary vessels. We have more microvascular disease. We're less likely to have that sudden onset of substernal chest pain, like an elephant is sitting on your chest. More likely to have a feeling of doom or shortness of breath or neck pain or back pain, a lot of non-specific symptoms. I have one patient in particular who was really healthy. She was an anesthesiologist, and in her 50s, her presenting symptom was syncope. Oh. It was the only symptom she had. And her labs were all normal. Nobody knew. Oh. And what we know on more of a systems level, and this is from a study that was done in Florida, when men and women present to the emergency room with a heart attack, acute myocardial infarction, the gender of the physician they see matters. So for female patients who see a female physician, their survival is 2-3x than if they see a male physician. Now, of course, present company accepted because you are amazing, Will Vanderveer. But, when you look at the female doctors and the male versus female outcomes, they're the same. So to me, this just shows the gaps that we need to address, the education that we need to be sharing with others so that we can close these gaps and we can all rise together and not have these massive disparities and these gaps that lead to the tragic case of a 52-year-old woman dying of a heart attack.
Oh, thank you, Sara. I'm really excited about this program. It's overdue. It's time, and we really enjoy collaborating with you. And everyone who gets a chance to learn from you raves about you. So, the website page for this program, I should mention, is our website, psychiatryinstitute.com/women. So it's very simple.
Oh, I like that. We can remember that.
I think so.
Even after
I hope so.
perimenopause, we can remember that.
psychiatryinstitute.com/women. Thank you, Sara, for joining me today, and really excited for this program.
Me too. And thank you for your leadership, Will. You and Keith bringing this forward and offering it to the world. It's just such a pleasure to be involved with you and to collaborate with you. Thank you.
Oh, thank you, Sara.